It's an exciting time in oncology and an exciting time to be a lung cancer oncologist. There have been remarkable improvements and treatments with immunotherapy for various solid tumors which are otherwise very hard to treat. We have seen remarkable activity with drugs targeting the PD-1, PD-L1 pathway in lung cancer, not just lung cancer, but various tumor types in patients who have otherwise had no alternate great treatment options. However, the major challenge in the field is the limited response of these drugs, and not everyone responds to these drugs, and in fact a vast majority of patients who get these drugs don't respond. And the challenge in the field is actually developing biomarkers to be able to use to select patients for these treatments. These treatments are extremely expensive. These are very expensive drugs. You don't want to be giving them to everyone out of cost consciousness. You've got to be choosing them wisely. So that's where my work comes in terms of actually using PD-L1 biomarker as an effective strategy for identifying patients who would benefit most for these drugs. So the data with PD-L1 as a biomarker for response to these drugs has been somewhat controversial. There have been mixed results from various industry-sponsored clinical trials using PD-1 inhibitors, and part of the reason why that is the case is because of the nature of the biomarker. Like PD-L1 is an inflammatory response biomarker, unlike the traditional targeted therapies where you have a genomic marker that is static or relatively static, which we expect to play a crucial biological role. PD-L1 is a molecule in the tumor that is upregulated when there is inflammation. Because of all these reasons, the timing of the biopsy and the location of the biopsy and the timing of the treatment post-biopsy play a crucial role in the importance of those PD-L1 as a biomarker for selecting patients with these treatments. And also, on that said, and also every drug company that's developing these PD-1 inhibitors or PD-L1 inhibitors has been using multiple different clones of antibodies with varying degree of sensitivity and specificity to PD-L1. And there's no standardization in terms of what we would define as a positive test and a negative test. And every clinical trial uses a different metric to determine what's a positive and what's a negative PD-L1 patient. So all these things make it very complicated to use PD-L1 as a clinically relevant biomarker for selecting patients. So that led us to think that we should perhaps look at all the patients who were treated with PD-1 inhibitors in clinical trials with various agents targeting the PD-1, PD-L1 pathway, and we evaluated systematically 28 trials which qualified to be included in the study. Based on the level of PD-L1 expression in those clinical trials and the responses with those agents. We did a comprehensive meta-analysis of all the 28 trials, including 10 lung cancer trials, which was a fairly comprehensive list of all trials that we used, including about 3,000 patients or over 3,000 patients treated with PD-1 inhibitors and a known PD-L1 biomarker. So what we found was that PD-L1, irrespective of tumor type and irrespective of the level of expression, is strongly correlating with the response across the board to PD-1 inhibitors. And what's most interesting is, especially in the lung cancer clinical trials, where we had enough patients with data on the cutoffs that were used, with the 5%, 1%, and 10% cutoffs for PD-L1, we found that 5% cutoff for PD-L1 would offer a clinically meaningful guide for selecting patients with, who could potentially benefit from PD-L1 inhibitors. The biggest challenge in the field is for biomarker is that you want to have a good negative predictive value. What I mean by that is patients who have had a negative biomarker, and that should select for lack of response. So you don't want to deprive patients of treatments that would otherwise be effective. The response rates in clinical trials, in most of the trials where they looked at a specific subset of patients with PD-L1 negative tumors, the response rates were fairly low compared to second-line chemotherapy. And that's where I think this actually plays a crucial role, and trying to identify a cutoff where you have a good balance between the negative predictive value and the clinical utility of the test, so that you enrich for most of the patients who respond to these drugs. And for those patients who have a negative PD-L1 that is like less than 5%, especially in lung cancer, because that's where we actually did the study for the cutoffs, various cutoffs, that would be a relevant cutoff to be used in the clinic for use of these drugs. Of course, there are a lot of limitations for this study. This is a large meta-analysis using various assays and various cutoffs and various agents being used. So there are a lot of limitations. This is a retrospective meta-analysis. Taking all that into consideration, I think this is food for thought, that having an optimal cutoff of a lower cutoff of PD-L1 and using that assay as a routine clinical diagnostic assay to select and enrich patients for PD-1 targeted therapies is crucial, and especially taking into account how expensive these drugs are, giving it to everyone and knowing that the response rates in patients who have no PD-L1 expression is so low. I think it's really important to incorporate this into clinical practice. And of course, it would be really nice if you can actually have more clinical trial data to support this. We do have studies planned for the future. Like we are asking different questions, not specifically looking at PD-L1 as a biomarker, but we have prospective trials which are investigator-initiated trials, not pharma trials. So we will be systematically interrogating the value of PD-L1 and various assays in those clinical trials, and try to determine what would be the optimal cutoff for a PD-L1 expression in those prospective multi-center trials. So the take-home message here really is that these are very expensive drugs. These are very promising drugs for a reason. Patients who respond to these drugs tend to have a long duration of response. However, most of the patients who respond to these drugs are patients who are able to mount an endogenous immune response. And patients who are not able to mount an endogenous immune response and have PD-L1 expression may not benefit from these drugs. So it is really critical to have biomarker development and incorporating biomarkers into clinical practice, so that we use these drugs more rationally.